All right, everyone. Welcome to Mini Med. Thank you very much for being here tonight. This is number 2 out of 4, or actually 6 out of 8, right? So thank you very much for being here. We're going to have a small crowd tonight, but there's quite a few online, so we're going to have a great night. I'd like to welcome tonight Dr. Suzanne Metcalf on her presentation on Bad to the Bone, a primer in osteoporosis. Welcome. Suzanne Metcalf is a family physician and a senior instructor faculty member at UC Health. She works at the Women's Integrated Services and Health Clinic at CU Anschutz. And prior to coming to UC Health, she spent her career working in community health. So let's all welcome Dr. Metcalf. Thank you.
Thank you, guys. So it's a pleasure to be here. I don't do a lot of presentations, so I'm a little honestly intimidated. So it's kind of nice to have a smaller crowd. Hopefully nobody throws tomatoes at me. But as long as they're ripe and fresh, I'm good with it. So we should get started. I do have quite a few slides. So I'm going to probably try to just sort of tell a story through this, and then and the data is there if you want more information there. So we're obviously here to talk about osteoporosis, which is literally a disease that is bad to your bones. And my goal for this presentation will hopefully be that you guys will understand a little bit more about like how bones develop and form, how we metabolize our bones, how they remodel themselves, how osteoporosis evolves, and finally just like the treatment and why it's such a critical issue for us. So just starting, osteoporosis quite literally is porous bone. Our skeleton is an organ system, there's when osteoporosis affects us, it is considered a systemic skeletal disease, and your bones just deteriorate. The mass goes away, and then thus that creates an increased risk for fragility fractures, and they're particularly the areas that we tend to experience those most are in our hip, our spine, and our wrist. So the personal impact of the disease is pretty great. Some of these statistics sometimes fly over your head, but some of this stuff is really shocking to me personally to know. So in the women who are over 45, osteoporosis results in more days spent in the hospital than even like a person who goes in with diabetes, a heart attack, or even breast cancer treatment. So you spend more time hospitalized, and usually that's because you're recovering from surgery and going through different complications of that. So this is crazy. 20 to 24% of people die in the first year after fracturing their hip, which is mind-boggling. Because I think sometimes people think that's almost like a rite of passage of our adulthood the older we get. So it's a huge burden. There's after a year, about 40% of people can't walk independently. So for folks who've survived that long, 60% of survivors still have to get some assistance. And you still, 80% of folks still can't go out and do basic things, go to the grocery store, go get your hairs done or your nails did or whatever. You can't do those things independently. So that's a huge burden. People, after a year, about 33% of people who fracture their hip, they're still in the nursing home, and you'll see this statistic later, but about 25% of people who break their hip, they never go home from the nursing home. So it's a pretty big disease burden, and it's an emotionally effective thing too, obviously. I mean, it's sad to lose your ability to go do the things you enjoy, to spend time with your friends, to go do the activities that you're used to doing. So, and obviously it's financially painful individually. Economically, on a larger scale, it's also pretty financially painful. So it's a top driver of hospitalization cost among U.S. women. So if you go in and have a stroke, you go in and have a heart attack, or you go in again for breast cancer treatment, it's more expensive to break your hip or have a significant fracture. And there's just so many downstream things that happen. Not only do you break your hip, but you have to spend time recuperating from surgery, go to rehab, potentially have those downstream effects of infection as well. And so that roughly, and this is older data, this is probably about from 6 years ago, annual economic burden was 22 billion. It projected to more than quadruple by 2040 to 95 billion. So it's an expensive disease. So this is a little bit shifting over to like, what do bones look like? And this is a normal bone, not an osteoporotic bone. And if you can see, so there's two important parts of bones that we have. And I'm sorry if this is a little bit blurry for you guys, but we have something called spongy bone, and you'll hear that called trabecular bone or lamellar bone. And then we have this stuff called compact bone. So our skeleton is about 20% spongy or trabecular bone, and about 80% of that compact or cortical bone. And this is just a good schematic of what trabecular or spongy bone looks like. It literally does look spongy, like a dish sponge you get out of a package. And there's a lot of blood vessels that go in there, and those blood vessels carry chemical mediators from your body, and it helps to carry signals from your body there. So this is just sort of an up close picture of the shaft of the bone, and this represents the bone marrow. And then this is all compact or cortical bone. So osteoporotic bone, it looks quite different than normal bone. So over on the left side, or your right, sorry. So on your right, you'll see that there is trabecular or spongy bone, and it's nice and dense and firm there. Osteoporotic bone is really super porous. It's almost literally like a fresh sponge that you get out of the package. It's ready to go, ready to wash dishes, and this is after dishwashing like 5,432. It is. It's really been ridden hard and put up wet, so to speak. So again, this is a good example of trabecular bone and a healthy spine here that doesn't have osteoporosis. When you get osteoporosis and you lose that density, as you can imagine, it's easy to compact that spine. And so things like compression fractures happen. And it's easy to imagine how that vulnerability really pushes down on the spine. So just a little bit about some of the statistics and who's at risk. So about 12.6% of Americans, again, data from about 2018, that's the early or most recent rather I could get, about 12.5% of us have osteoporosis, men and women. Out of that, folks over the age of 50 were estimated about 20% of women, roughly about 4.4% of men have osteoporosis. And interestingly, the incidence is going up, probably a lot to do with hesitancy about taking medicines for it. So, thinking about the prevalence of low bone mass. So you guys may have heard of a term called osteopenia. Osteopenia is now called low bone density. So in this case, it's listed as low bone mass, but it's about 43%. So you don't quite meet the criteria for a diagnosis of osteoporosis. And again, it's more common in women than men, and that has to do with the fact that we go through menopause and lose our ovarian function, and estrogen's real important for bone growth. And anybody can get this disease, but women, especially Asian women and Caucasian women, are way more likely to develop the disease than other folks. And there's genetic factors that cause that. So And if you think like after, if we survive to age 50, I've got a year and a half, I'm hopeful. So if we survive that long, about 1 in 2 or 1 in 3 women are going to go on in their lifespan and get an osteoporotic fracture, and about 1 in 4 to 1 in 5 men will have a fracture in their remaining lifetime. And then other risk factors, and we'll kind of run through these. So family history of broken bones, specifically if like your mom or your dad had a hip fracture, you know, some sort of osteoporotic or fragility fracture. If you yourself have broken a bone after the age of 50, that increases your risk. Surgery, so if you have surgical menopause, somebody takes your ovaries out before time, before you go through a natural menopause for women. So people who have terrible diets, they don't include a lot of vitamin D or calcium or protein. And the folks who are maybe immobilized for a long period of time, you've been in the intensive care unit, you've had a major injury, smoking, drinking, alcohol, those are things that can definitely increase your risk. And then medicine, so everyday stuff we use. I might take this off and just hold it, if that is okay. I think that might work better. So everyday stuff we use, kind of like, you know, think about omeprazole or like the Prilosec that you may use for your acid reflux. Long-term use of that increases your risk of osteoporosis. If you have a medical reason to take it, though, you're trying to prevent esophageal cancer because you got a problem with your esophagus, then that can be problematic to stop it. So some of these drugs are medically necessary. Long-term use of steroids, you can't just automatically stop those. And of course, epilepsy medicine, you don't want to have seizures. So, but those are some unfortunate side effects. And then hormone levels, like as women get older, our estrogen levels either will naturally wane if we still have our ovaries intact. Men will have a reduction in their testosterone. It's just slower and not as great. So, and then if you're really underweight too. So let's now kind of switch our focus a little bit on when bone starts to develop. So when you're an embryo, when you're an embryo, which is this stage here, this is about 6 or 7 weeks of human formation. So this is a little embryo, and there's the little placenta, and there's the umbilical cord. So this embryo is starting to develop bone and lay down bone. It's called osteogenesis. And then it goes on until you're 25. So this lady right here, presumptively 25, that's what they said on the internet when I got the picture. So, and you don't get taller but much taller after like 18 to 20, right? But there's still that evolution and that perfection in formation until about age 25. So interestingly too, this is where we all come from. So this is very early after the sperm and the egg meet and fall in love. They form 3 separate layers of tissue. There's the ectoderm, the mesoderm, and the endoderm. So, and the mesoderm that's kind of the stem cell layer. That's where bones come from. Mesoderm spits out these cells called mesenchymal stem cells. And then those go on to kind of give birth to osteoblasts, which are heavily important in our bone formation. They like to build, so osteoblasts build, and osteoblasts then form osteocytes. Osteoblasts and osteocytes are bone cells. So I'm going to stay off the next slide for a second because it's a little dense, and I'm going to try to tell a story over here. So these stem cells, they have a lot of potential to become different cell types in our body. So they can become cartilage and they can become bone, amongst other things. So Ultimately, when they give rise to these osteoblasts sort of oversee our bone formation. They're in charge of regulation of the process of bone development and bone breakdown. And your bone is constantly remodeling, constantly reinventing itself, I should say. Remodeling is the right word, but so it's like an Instagram star that's looking to like perfect itself and get better all the time. So osteoblasts, they regulate this type of cell called osteoclast. So I'm going to move on to the dense slide. I'm sorry in advance. So we've kind of reviewed osteoblasts already, but osteoclasts, they like to break down bone, and it's super cool, I think, how they do it. So they're this type of cell called macrophages, which I think of as kind of like hungry hippos. They will eat anything. So macrophages are sort of designed in our immune system to break down tissue. In the osteoclasts, they actually use hydrogen ions. So they use acid and they go in and they break down your bone, and they're regulated by osteoblasts. So and then finally, what happens to those osteocytes? They're kind of the foremen almost. And if we think about this as maybe a construction site, the osteoblasts are there to like lay down the drywall and everything else. Osteoclasts are there to tear stuff down, and osteocytes oversee that. So that's kind of like how our bone forms. And so, like I said, it's just highly metabolically active. So, and it's continuously remodeled. And that's just a restatement of the obvious. So here's my little analogy. Osteoblasts, they're the builders. Osteoclasts like to tear stuff up. The osteocytes are the ones who are overseeing the process. And then the osteocytes, they take messages from these local and systemic factors that come into your bone. So they help, they take the advice of the home builder, and then they go tell the osteoblasts and the osteoclasts what to do. Osteoblasts oversee osteoclasts. So eventually, though, unfortunately, sometime around mid-age in women and a little older than men, our osteoblasts and our osteocytes start to, like, they get older, they get tired, they want to retire, they may die off, but the osteoclasts always run strong. So I kind of think about osteoclasts as sort of like, I don't know, a destructive gang and like a trap house or something here with they're using graffiti on the walls. So that's kind of a little bit of an idea of how that functions. And there's a question, how quickly do we lose bone? What happens in terms of bone loss? How much do we lose, I should say? And like in men, you'll lose 45% of that spongy bone by the time you die. In women, we'll lose 55% of that spongy bone, which makes up about 20% of our bone mass. And then men lose about 18% of that hard-formed cortical bone. And women, we lose a little bit more, 25%. And women hemorrhage bone by the time we get to perimenopause. This says menopause, but truthfully, perimenopause, when our ovaries start to fail, you drop 20 to 30% of your trabecular spongy bone and roughly about 5 to 10% of the cortical bone. And that's just referring to the, oh, darn it, I keep on doing that. So this refers to where that goes. So the trabecular bone loss is measured at has been measured at the spine in terms of the quantity of loss, and then the cortical bone at the radius, so which is in your wrist. So it's a lot. And if you don't do anything about it, it's just going to get worse. Like you will never, it doesn't get better on its own. We have to intervene for this. So this is just a good graphic representation of exactly what I just said. So, and this the x-axis here is your age in years, assuming you live to be 100, and the y-axis is like what's your bone density there. So we already talked about the first 25 years are spent in sort of bone development and sort of getting that together. When you're 29, that's the densest your bone is ever going to be, and then it's all downhill from there. As in many things in life. But if we look, it's actually fairly static. So this is men up here. This is women down here. It's fairly static until us women hit that perimenopause, and that's where your bone density plummets quite a bit. And then roughly about the age of 65, 70, we're going to meet our male counterparts, not in the same degree of bone density, but in the rate of loss. But men always have higher density than women because they maintain their testosterone levels longer than us. That probably was an accidental slide I just led as a space builder there. So moving on to fragility and what happens when we get fragility fractures. So a fragility fracture is a fracture, for example, if I fell backwards and fell on my bottom here, if I broke a bone in my spine, that would be considered a fragility fracture. So it's ground level fall or less. So it's kind of minor injury with significant injury or significant impact, or I should say minor fall, significant injury rather. So, and it's a fragility fracture is sort of the ultimate indicator that you have osteoporosis. If you've incidentally been found to have, a compression fracture in your lumbar spine, if you have a minor injury with a wrist fracture, or obviously if you fall minor injury and still fracture your hip, that's a big deal. So, which we just said, hip, spine, and forearm are considered to be fragility fractures. If you go in and fracture your ankle from a ground level fall, you may not necessarily be recognized or diagnosed with osteoporosis because the validated sites are hip, spine, and forearm. Not to say that you can't break other stuff. And it's crazy, people will come in with these vertebral compression fractures and they never knew they had them. I mean, it's just, it's amazing that people can withstand pain. If you've ever worked in a hospital scenario or had a relative or a friend who's broken a hip, it's incredible that people will sometimes walk around potentially on that, or they just don't feel as much pain as one would experience, but they suffer a lot from the consequences of it. So again, on the right side, I keep on pressing that button, don't I? On the right side, you've got this nice, dense, spongy bone, and then we've got this kind of raggedy osteoporotic bone here. This is a normal spine, and then this is an evidence of compression fracture. So it's easy to see if you literally took that bone and it was sitting on a table in front of me and I pushed it down, it smushes the bone down. And that's kind of what happens when you get a vertebral compression fracture. That's why some of us lose height. You'll see sometimes we become more kyphotic as we age, and those are often from compression fractures. So this is just an x-ray, and I apologize, it's a little bit blurry, but just to kind of show you essentially the difference. So all of these people weirdly have a compression fracture, but it's way easier to see this is not right, then you can see this is not right. So it can start pretty minor, and it gets under recognized because people don't realize sometimes that they're looking at a compression fracture. So this one is minor, grade 0, and you can kind of see there's maybe a little V shape sort of right there in the bone. This is a little blurrier, but this bone has become just smushed down a little bit more. And with progressive smushing or crunching of that bone, and these are different people, they can become quite small. So the distance between these two lines, that represents the top and the bottom of the bone, it's closer together. So, and you can imagine how that would reduce someone's height. In terms of hip, this is just a sort of like a soup du jour of where you can fracture your hip. So these are different zones, but hip fractures, you may hear this terminology if you've ever experienced, unfortunately, one yourself or other folks. This is a intracapsular fracture. It's close to the joint. And then this one's called a trochanteric or a trochanteric fracture, and then a subtrochanteric fracture. So, and there's just different parts of the anatomy of the bone in the picture of the right side. And then the next one shows that trochanteric fracture. There, you can see that dark line is not supposed to be there. So this is a person who's fractured their hip. And then this is kind of the outcome, like what happens, what does it look like after you've gone to surgery? So you can either end up getting your hip, the ball part of the joint, because it's a ball and socket joint, removed, and then it gets replaced with a prosthetic device, or someone can come in and nail the hip back together. So you have to have pretty good bone to do this. If you don't have good texture of the bone, you're probably going to end up with this guy. And these are just x-rays of post-hip surgery. So of a replacement and then nailing of the bone. So how do we kind of, I guess, shifting gears now, how are we screening for this and looking for osteoporosis? How do we detect it? So there's these, I'm sure you guys, some of you guys here have possibly had DEXA scans before. And DEXA scans are low beam x-rays, and it stands for dual, oh my gosh, I'm having a complete mental breakdown. I'm sorry, dual energy x-ray absorptiometry. And so it's pretty cool because you could look at your hip, your spine, or your wrist and estimate how much like mineral content, how dense are your bones there. So we already know this, low bone density is increased risk of fragility fractures. And the way that you look at a DEXA scan, it's got a scoring system called a T-score. And so in men, so postmenopausal women and men 50 years or older, you use that T-score. And it's a comparison of your bone density as a 50-year or older person to an individual's bone mineral density from a young adult mean bone mineral density. So anyway, you compare your bones to young adults and see how much bone density you've lost. So let's see here. And this is just a sort of a graphic representation or a chart that sort of shows what's your status on the left and then what's the bone density on the right. So on the left, if your bone density is normal, the T-score is reported -1 or above, which is kind of a little bit mind-boggling. So -1, -0.9, -0.8. So the less negative, the more normal. Low bone density, which we know as osteopenia, is between -1 and 2.5. Osteoporosis is -2.5 or lower. And then if you got real bad osteoporosis, you had a fragility fracture and your T-score is -2.5. So and this is just kind of a little blurry or a lot blurry, but sort of like what this is a DEXA scanner, and this person is getting their DEXA scan done. We've already said hip, spine, and wrist. And this is kind of what a DEXA scan report looks like. Ours is a little bit different. We don't get we just get a bunch of words on a page, so we don't get any entertaining images there. But so, and the green represents normal density, the yellow would represent low bone density, aka osteopenia, and the red is osteoporosis. So And so one thing that we can do on those DEXA scans is, let's say you fall into the low bone density range, but maybe you've got a little bit increased risk. We do this thing called a FRAX score. We want to try to capture people before they start suffering from this disease, right? Because sometimes when you have severe osteoporosis, it's almost you're intervening too late. So it's just a surrogate marker or clinical tool, and you can actually calculate your own FRAX score. There's a website for it, and I've included it below just for fun, if you guys want to go home and calculate your bone density. So it's just a validated tool that uses that, and it stands for fracture risk assessment. So here's my FRAX score, and now everybody knows how much I weigh and how tall I am, and how old I am. So I've never had a DEXA scan, but you can still calculate it from it. So, but here, this is probably the most important part. So your FRAX score sort of projects in the next 10 years, how likely are you to have a major osteoporotic fracture? And you would think hip would be included in a major osteoporotic fracture, but it calculates hip fractures separately. So let's say a person maybe falls into that low bone density osteopenia score. We talked about the T-score, but his or her FRAX score is greater than 20% for a major osteoporotic fracture, or more than 3% for hip fracture. That person's at high fracture risk, and you would treat them as though they had osteoporosis, not just osteopenia. So, and then who gets tested and when? So the National Osteoporosis Foundation suggests all women 65 years and older get tested, men 70 and older, which is definitely an underrepresented group. I mean, there's so many men who have not been tested. And postmenopausal men and women who have additional clinical risk factors, we'll go over what those are in a moment. And if you're 50 or older, so if you're a postmenopausal woman of any age, or if you're 50 years of age or older, and you've ever had a fracture, so one of those fractures that seem to be suspicious in adulthood. And then I'm going to, the additional risk factors, I might race through a little bit, but obviously if you've had a fragility fracture, sometimes people are like, well, that begs the question, well, like, why would you even get a DEXA in that case? But you still need the numerical values to consider treatment. If you've had low bone density identified on like an x-ray, the radiologist says, hey, that person's, the x-ray of their shin looks like their bone mineral density is low. So if you've been on steroids for a real long time, that's an indication. We just talked about the FRAX score, so the increased risk of major osteoporotic fracture. I hate it when it does that. That's my fault too. And then early menopause too. So a woman who stops bleeding before the age of 40 is considered premature ovarian insufficiency or early menopause. And then there's all like kinds of systemic disease. So if you have, certain endocrine or metabolic diseases, some people have this thing called hyperparathyroidism. Nutritional, if you've had bariatric surgery or things like that, you can't absorb quite as good. Those are reasons to test. And of course, obviously smoking. So finally, moving on to what do you do about this? So the first thing we tell people or one of the things we tell people, I'm not sure it's absolutely the first, is exercise. Exercise is modestly increases your bone density, but what it can do for you is improve your stability. So if you're a little bit more stronger, you're less likely to have a fall. And so fall is what creates all of these problems. So So strengthening your muscles, definitely, and resistance training. Everybody's into weight training now, I feel like. At least it seems like it at the gym. You can never get a piece of equipment to save your life. But and you would do weight bearing means a little bit of like a weight lifting, and that can be body weight. Or that can literally be lifting weights. In doing those two together over 12 to 18 months can provide some modest improvement in bone density and just your overall physical performance. And typically you feel better. It also helps with things like osteoarthritis, obviously obesity. And so yoga, a lot of people love yoga. You just have to think about some of the rotational movements with yoga or extreme flexion. If a person has a potential for osteoporotic fracture in their back, that could spell disaster. So yoga should be modified not to do those types of things. And finally, Tai Chi. So Tai Chi definitely reduces falls. There's definitely an overall benefit in bone health. And there's reduced pain for people who have stuff like arthritis. So obviously graphic representation of what I just said. I'll just point out, I love this woman. So she's like in her early 80s, I think, and she's the world powerlifting champion for her age range, which sounds like she wouldn't lift a lot in her age range, but she's, hundreds of pounds. She's pretty incredible. So obviously adults doing Tai Chi. And just to mention, you don't have to go out and start running right away, obviously. You can certainly do intensive physical activity, starting with walking, and building up always is beneficial. So just a calcium and vitamin D, I feel like often come up and people ask, what kind of calcium should I take? What kind of vitamin D should I be taking? So there's definitely improvement in people who have calcium and vitamin D optimized. It's really important. Your bones consist of calcium and utilization of vitamin D for their integrity. There's definitely people proven that older folks who have lower vitamin D levels are at increased risk of fracture, and they have less muscular strength. So institutionalized people who get vitamin D replacement may be at risk of reduced falls, possibly from improving muscular strength and so forth. So in oral vitamin D, if you use supplements beyond your diet, the daily supplements are better. Sometimes you'll get these monthly massive vitamin D doses, or you'll have other forms of vitamin D. So those actually maybe possibly could increase your risk of falls versus prohibiting falls. So daily vitamin D intake is better. And then finally, how much do you take? 1,200 of calcium a day and about 800 international units of vitamin D is what's recommended for folks over 70. Also, menopausal women, I usually start them on that way earlier. So dietary sources are always probably better. Cod liver oil is amazingly full of vitamin D. I didn't even realize how much it was till I looked at it earlier. So fish, vitamin D sources are kind of limited. So it looks like there's a long list, but if you think about it in comparison, calcium's in a lot of stuff. So this is your exhaustive list of vitamin D dietary sources. So apparently sardines contain a lot of calcium and vitamin D. I did not realize quite how much. So those are dietary options for folks to help ensure that you have adequate replacement. And if you can't replace it, then an over-the-counter vitamin will do. You can get too much vitamin D, though, and actually too much vitamin D can leach calcium from your bones, so it's not good to use too much. And then finally, like stuff we prescribe. So who needs to get treated? So we've already talked a little bit about the idea of fragility fracture. So a fragility fracture really with any T-score, but especially the T-score that's between -1, -2.5, that's the osteopenic or low bone density range. You should be on some form of pharmacologic therapy. If you have a T-score less than 2.5, that's kind of a no-brainer. That's defined as osteoporosis. Again, you ought to be on therapy. And then folks who have, we talked about the idea of the FRAX score. So if you fall into the low bone density range, -1 to -2.5, but you have that 20% chance in 10 years of getting a major fracture, or a 3%, that should have a percentage behind it, sorry, chance of getting a hip fracture in 10 years, those are reasons you ought to be on therapy. So there's a whole list of medicines for this. These are going to come up in a weird order but there's a lot of pharmacologic ways that we can reduce bone loss. So probably the ones you guys know about are bisphosphonates, and those are called anti-resorptives. Those actually inhibit those osteoclasts. They prevent them from attaching to the bone. Prolia is pretty popular. It's a once every 6 months subcutaneous injection. Estrogen, obviously limited to genetic females, and only can be given during a certain time of our life. So there's certain drugs called selective estrogen receptor modulators. One of them contains estrogen too. Those are probably a little bit less popular because they are associated with increased vascular risk. So you can get like blood clots and stuff like that from them. Using them at certain points in our life is probably safer, but later we might transition over. And then we have these things called anabolics. So Forteo, there's one called Tylos, and they rapidly build up bone. And finally, there's this drug called Evenity. Yeah, I can't say that. It's kind of cool because it's both anabolic and it has properties similar to the bisphosphonates that's anaresorptive. So, but a little problematic. So, this is sort of just how these drugs measure up against one another. So you want to see, like, if you have a plus sign in all three of these boxes, it reduces vertebral fracture, reduces your risk of non-vertebral, like wrist fracture, reducing your risk of hip fracture. That's good. The more types of fractures it can reduce, the better. So the fewer types of fractures it reduces, the less superior of that drug. So the ones, and we'll go over this, but drugs that are called bisphosphonates have the best data on reduction of hip and spine and non-spine osteoporotic fractures. Evista probably has clearly the worst, along with, interestingly, Boniva. Boniva is a bisphosphonate. Sally Fields used to do I always remember their Boniva commercials, but anyway, it's just not as good of a bisphosphonate. And then finally, some of these drugs, the other one that's really good is Prolia. So the other drugs can be helpful, but it is optimal to have a drug that does all three sites. So I'm going to spend I know we're kind of wrapping up a little bit. We got about 7 more minutes. I'm going to try to talk fast. Bisphosphonates. Whether oral or IV, except for Boniva, they're the most commonly prescribed form of therapy, and they're really effective. We talked about they prevent osteoclasts, so they bind to the site in the bone that the osteoclast would normally try to go and destroy. And they prevent that destruction, that use of the acid of the bone to destroy the bone. They're pretty effective, 40 to 70% reduction in the risk of vertebral and hip fractures, which is pretty amazing. But this is the thing that always that really gets to people's heads. And so we're going to talk about this for a sec. Prolonged use can cause extraordinarily rare, and I'm going to show you how extraordinarily rare, but extraordinarily rare side effects, including an atypical type of femoral fracture, so thigh bone fracture, and osteonecrosis of the jaw. And so that means breakdown of your jaw. So a medicine that's supposed to build up your bone, unfortunately, can cause that. The nice things about this group of drugs is you use them for 3 to 5 years and then reassess your bone density. And if it's better, you get to stop it after that. That's not the case for any of the other drugs. And then you have this like drug holiday. And then you just follow a person's bone density along. So these are just a few slides to show like how rare osteonecrosis of the jaw is, which is down here. So this is from a study done on women who lived in Olmsted County, Minnesota. And this is the risk per 100,000 people per year. So imagine if you put 100,000 people in the Bronco Stadium and you left them there for a year. I'm not sure that any of them would survive, but let's just pretend they did, and everybody was happy and okay with one another. So any fragility fracture out of those 100,000 people, you're going to have about 2,600 people who get a fragility fracture. Out of those 100,000 people, 387 are going to get a hip fracture. Now imagine you take a bunch of penicillin and shoot everybody up with penicillin there. Only 32 of them will get anaphylaxis, which is a horrible allergic reaction. Somehow everybody got cars in the Bronco Stadium and 100,000 people are driving around miraculously. Only 11 people die in that case. Now, also equally miraculously, only 6 people get murdered in that. And then less than 1 person gets osteonecrosis of the jaw, and 1 unfortunate person gets struck by lightning. So that kind of sucks. But point being, osteonecrosis, super rare. This is just sort of another illustration that in people, an 80-year-old woman who is not treated for her osteoporosis, she's got about a 25% risk of an osteoporotic fracture that goes down to 12.5, so 50% reduction. If she gets a bisphosphonate, there's about a 0.01% chance she'll get osteonecrosis of the jaw. So pretty low. And also finally, like if we think about how bisphosphonates have changed osteoporosis therapy, using a seatbelt reduces your risk of motor vehicle accident or severe injury or death from motor vehicle accident by about 50%. And treating with bisphosphonates similarly reduces your risk of fractures of the hip and spine and other non-spine fractures by 50%. So they're powerful drugs that people are unfortunately afraid of. I'm probably going to race through because I want to make sure we have time for questions, but Prolia is pretty effective. Prolia is called a monoclonal antibody, and bisphosphonates and Prolia are the most commonly used drugs. So it does a better job in building up your bone density, but you have to use it forever. You can never stop it. And if you miss it, like it's every 6 months, if you miss it, your bone density rapidly reduces. So it's very particular. Estrogen, obviously, we said can only be used at certain times of our life and in certain genders. And then we've got these, and this is super wordy, so I'm just going to try to break this down. These anabolic agents, so the ones that were called Forteo and Tylose, they're expensive. They're very effective. They build up a lot of bone, but only in your spine. They don't do anything for the hip, so that's problematic. But they work great. You use them for about a year, and then you transition over to a bisphosphonate. But they're daily subcutaneous injections and they're expensive. So there's a high level of attrition. People just stop using them. And romosozumab, unfortunately, increases your risk of cardiovascular disease in certain people, not everybody. This is something that an endocrinologist, not a primary care doctor, would use. So that's something to think about. And then people, in closing, I promise, that people are just hesitant because they get into that, the osteonecrosis of the jaw and the atypical femoral fracture, and they get scared to use the drugs. And there also can be associated reflux with bisphosphonates. No drug is perfect. We always have to look at risk-benefit ratio, but I think it's just important not to be afraid of those drugs in treatment. And so people, like the proportion of people receiving appropriate therapy has decreased, I suspect, due to social media, like bad mouthing drugs, So I think it's important that people like use good sources to make their decisions. So, and just like there's a reluctance to adhere to therapy. So, and finally, this last slide. So roughly after, if in people who've had an osteoporotic fracture, 80% of them are not either identified or treated after that first fracture, which is a huge burden. There's going to be over 60 years between 1990 to 2050. There's going to be a 240% increase in women having a hip fracture and 310% increase in men having hip fractures. And the last part we've already talked about, about 33 to 50% of women over the age of 50, and 20 to 25% of men over the age of 50 are going to have a fracture in their lifetime. 300,000 fractures annually, and 25% of people never leave the nursing home, and 25% of people die. So with that, they're getting up, so it's time for questions. So thank you.
Thank you so much. All right. We're going to alternate questions, starting with the audience, the live audience, and then going to the online. So does anybody have any questions?
So you mentioned that osteoporosis can be genetic. So I was just wondering, can it also be received as a recessive gene? Like if somebody's grandpa has it, the dad doesn't have it, can the kid have it?
Oh, I knew you were going to ask a hard question, and I'm not sure about that. It's a good point. There are certain, when talking about like certain groups of people, it's probably more from a perspective, a greater risk from an ethnicity perspective. So Asian women are of great likelihood, Caucasian women too. Some of that too, like if you think about spending a lot of time indoors, we don't get as much like natural vitamin D from sunlight because it's not, you'll get skin cancer from that potentially. So there's probably more of a specific ethnic linkage there, but there certainly can be some instances where it could possibly be passed on. You're more likely, if my mother had an osteoporotic fracture, dad did, I am more likely to have that. The precise genetic mechanism, I can't tell you, but I can find it out. Yeah, please.
All right. From the Zoom chat, can a car accident increase later bone fractures?
Typically not necessarily, unless if a person's bone fracture, I'm assuming they mean like injury related to that. But if a person's injury relational to the accident was due to osteoporosis, one osteoporotic fracture often begets more fractures. And that's because people, when you have fracture, there's a level of suffering, there's a level of disability that happens after that. You have to recover from it. And then you lose some balance and strength. So that can be problematic. So if it's relational to osteoporosis, I guess the answer is yes. But just a random fracture that occurred as a motor vehicle accident, not related to osteoporosis, no. Everybody's ready to get out and get supper.
So I know everybody has to weigh the pros and cons of all of the medications, but so you were saying that the certain ones, the
Bisphosphonates.
yeah,
That's okay.
Have more benefits. So is there are there some that you would recommend more than others?
Yep, Fosamax is probably the one we tend to use more often. It's got a lot of long-term information on it. Actonel's been around for a while too. Fosamax is a once-a-week drug, and it's pretty cheap now. It's been around as long as I've been practicing, which is a long time. So in terms of efficacy and affordability and probably tolerance, that's one that we tend to probably use the most and has probably been studied the most.
All right, I have another one from the Zoom call. Can you make any comment on bone quality with medications?
I might need to have a little bit more information for that one. I guess bone quality is important. So if we think about so you can be a younger person and your existing bone quality and how good it is will be sort of a determining factor of whether or not you later develop problems with your bones. Folks with better bone quality, and that's something that's probably a little bit beyond my scope of this talk particularly, but a person who has a better, kind of a better foundation of bone, or they're less likely, and that may be too thinking about folks who are, like we talked about Asian and Caucasian women, there may be an inherent degree of bone quality, poorer bone quality that might predispose towards greater osteoporotic fracture. That's the best I can do, sorry.
Since walking regularly and regular physical activity slightly increase bone density, it should be the first prescription as intervention prior to RX drugs, correct?
Typically you would use it together because, and it depends. So I start by telling people, I've actually started, since I did this, talking to women even in their 30s and saying like, now's the best your bones are ever going to be. So it's really important to start building those healthy habits. Now my population is women, so I would talk to men about this too, if I had them, to be fair. It's certainly built up. Because there's a modest improvement, it's usually, if a person falls into the reasons that we talked about for pharmacologic treatment, you use everything together. And the reason for that is you'll receive quicker benefit. If you only do lifestyle intervention, just your risk of fracture increases a little bit. And it's hard. People want to do, obviously we want to take a natural approach first before we take medicines that may have side effects. So everyone has to sort of choose what they want to do. But if we look at statistical data and think about like bigger populations, it's definitely proven that those things together work better.
I have a teacher's place.
Yeah.
How long is Fosamax effective? You take it 3 to 5 years, you take a rest. How long would that be considered effective in terms of protection, say during an osteopenic phase?
Yeah, it's typically it will vary, unfortunately. So the answer is there's not a one size fits all for everybody. Those are patients that you would follow with DEXA scans fairly regularly. So after 3 to 5 years, if you start to follow them over time, you might follow them at 2-year intervals, depending, 1 to 2 year intervals. And then you're looking to see like what's the rate of fall. So if someone maintains stability, because none of the drugs, nobody knows how long you can safely use any of these drugs, even though they've been around forever. There's not a lot of longitudinal studies looking at that. So you have to follow each patient individually and start to see if their bone density reduces, then is it worth using the medication again? And you know, just again, thinking about the patients, their personal preferences, other comorbid illnesses, their lifespan and longevity. So all of that plays in. You're welcome. Mhm.
Do older adults generate lower levels of natural vitamin D as they age?
Well, vitamin D is, interestingly, we get typically from our sun exposure. So we are less likely to be out in the sun again because, I mean, this is Colorado. I'm getting a skin cancer cut off my face in 2 weeks from now. So it is, we definitely spend less time outside. And there's a lot of burden to skin cancer. I mean, melanoma is deadly, obviously. So we don't tell people to go out and spend time in the sun unprotected. So it's more exposure really than self-generation of vitamin D. And so that's why it's really important. You want to optimize a person's vitamin D even before you start therapy, for sure. You guys
Thank
appreciate it.
Dr. Metcalf we appreciate you. Thank you. All right. The next slide is going to show you the post-session survey. Please fill that out for us. Next week's session is our Frontiers in Medicine, which is going to be live from Mesa County, Colorado. The title is Vaccines Increasing Understanding, presented by Dr. Corey Klein. So thank you guys all for showing